Good afternoon. Thank you all for joining in and spending this Tuesday afternoon, a few minutes on a Tuesday afternoon with us. Today I'm going to talk about some tendon issues that we see very frequently in the upper extremity, and I'm going to focus on the three most common things that we see in the hand, wrist, and elbow. Before we get started, as I was putting this together, I was thinking it probably makes sense to just talk about what a tendon is. So tendons are basically the strings that connect our muscles to our bones. So as you know, when a muscle contracts, it shortens, and then when that muscle pulls on the tendon, it pulls, then the tendon connects to a bone and it makes that bone move at one of our joints. And so today we're going to discuss the three most common things that I see in the office with regard to hand, wrist, and elbow. So just no financial disclosures or with products or anything like that. So again, our goals today are going to be to discuss the most common tendon issues that I see regarding the hand, wrist, and elbow. And we'll start off with the hand. So by far, the most common tendon issue that I see in the hand is something called a trigger finger. So this is a condition where the tendons can get, most of the things that affect tendons involve some inflammation. And this one does involve some inflammation. And I'm going to go over this little picture because sometimes pictures are helpful to describe things. In these two pictures, you can see the gray portion is the tendon. And as I had mentioned, tendons connect muscles to bones. So the muscles aren't pictured here, but you can see where there are, this isn't a completely 100% accurate picture in terms of where the tendons connect. But if you can imagine on this side, the tendon moves forward down towards the forearm and connects to a muscle. On this side, it connects to the bone. When that tendon gets pulled in this direction, in that direction, then the finger is going to bend. So the tendon also has a little bit of a little sheath around it. We call it a tenosynovium. And sometimes that sheath and the tendon itself can get inflamed. When it gets very inflamed, then you can get a situation that happens in that second picture where it gets sort of bulbous, little nodule, almost like a little nodule that's there. Now you can imagine as that tendon travels through this little tunnel is called a pulley, okay? And that just helps to keep the tendon next to the bone so things don't bowstring out as you bend your fingers. So as this nodule before you bend your finger starts out over here. As you bend the finger, it goes through that little tunnel, and if it's big enough, it can get stuck on the other side, and that can cause the finger to get stuck in a bent position. When the little nodule, the inflammation isn't too bad, we get catching. If it gets really bad, the finger can actually get stuck in a sort of lock position. And sort of on the other end of that spectrum, sometimes it doesn't even catch or lock. It just causes discomfort in that area, typically around this area, especially when you're grabbing a hold of something, if you're holding a bag of groceries or, or pulling something. But the actual mechanism involves that swelling of the tendon as it goes through these little tunnels. So just a little bit of background on trigger finger, a little bit more common in women than men. There's not a direct link between things like diabetes or kidney disease or other rheumatologic illnesses, but we do see a connection where folks that have some of those conditions do tend to get this a little bit more frequently. And, the reported order of frequency in terms of which fingers are the most common to see it are the thumb, followed by the ring and long fingers, and then the index finger and the small finger. We certainly do see it in all the fingers. Just another little schematic here, and sometimes on the right, that's how people will come in with the finger in a bent position, and you sometimes will say, "Oh, I gotta pop it open this way," or sometimes I have seen even folks come in where they can't even get it open. So in terms of treatment, there are a number of different things you could do. So you'll see some common themes throughout the talk in terms of things that we do for some of these conditions, but the finger is affected when it's bent. That's when it gets stuck. And so we do sometimes keep it splinted in an extended position, mostly just at bedtime when you sleep. It's hard to walk around everyday life with your finger in a straight position because we always have to grab things. So at nighttime, we tend to retain a little bit of water. So keeping it a little straight sometimes helps to keep that inflammation down and helps even into the day. Cortisone injections are the most common thing that we do for this. It's a cure 60 to 70% of the time. is possibly a little less effective in folks with diabetes, and it does have the added potential risk, not guaranteed, but potential risk of elevating the blood sugar temporarily in folks with diabetes, but it typically is very effective. In my practice, I typically will give folks up to 2 injections for this problem. So, for example, if you have an injection and things get a lot better, and then 6 months later, some arbitrary time later, it comes back again, we'll discuss the different treatment options again, and potentially we'll do another injection. If it comes back again after that, then we typically talk about the sort of the last resort, which is a surgery. Hopefully nobody's squeamish about looking at, that's what the tendon will look like. And it's typically a small incision like that, where you basically just open up that little pulley from that I showed you in that previous slide. You just sort of, I sometimes use the example of if you tied a knot in your belt and tried to pull it through the belt loop and it gets stuck, that's kind of what's happening with the trigger finger. So in this case, we're just cutting the belt loop so it can't get stuck anymore. There is a way to do it through what's called a percutaneous needle release, but that adds a little bit of risk to some of the structures in the area, like the arteries and nerves. So I typically just do it through a small incision like you see in that picture. So that's trigger finger. Let's move on to talk about the wrist. The most common condition that I see involving tendons in the wrist is something called de Quervain's tenosynovitis, which is a fancy name for something that has the nickname also of mommy wrist, because we do see it in a lot of new mothers and also new grandmothers, new fathers too. I remember when my daughter was a baby, I remember holding her at one point and sort of trying to calm her down and starting to feel this in my own wrist, thinking like, oh, so this is what my patients are feeling. So it is a little more common in women than men. Again, about a 6-to-1 ratio in that respect. And I'm going to show you some pictures, but it's pain along the thumb side of the wrist. We suspect picking up the baby constantly is one of the sources, and that's why I got that nickname. So this is just a little picture, if you can see, and I included the fancy names of these things on the slide just in case you ever hear it. But stenosing tenosynovitis, all that means is things are getting a little stuck because they're really inflamed and it hurts. There's 2 tendons that mainly control the thumb that are involved with this. Now, all of the tendons that run along the back of our wrist that help to make our fingers go up and our wrists go back go through little compartments. This is a schematic just showing a couple of those compartments, but this first compartment that controls 2 of the tendons that control the thumb is the one that's involved with this particular condition. And the fancy names of those tendons are the abductor pollicis longus and the extensor pollicis brevis. The typical sort of most common anatomic arrangement of those tendons is that you have those 2 tendons in one compartment. Sometimes people will have different anatomic variations that are all normal. It's just sort of how we're built. Some folks will have sort of, instead of just one of these abductor pollicis longus tendons, sometimes people have 2. The other thing that I frequently see when people do get to the surgical point with this is that this extensor pollicis brevis tendon sometimes has its own little tiny compartment within the bigger compartment. So you can imagine if you start making things, you start narrowing that space if you add additional compartments, and that is often the reason why folks will end up in surgery if it doesn't get better with some of the conservative treatments. So again, we discussed a little bit about some common themes amongst these the treatment options for these conditions, and wearing a brace at night that keeps things sort of in a functional rested position can be helpful. Again, we tend to retain water at night. We tend to curl up in funny positions when we sleep, and so immobilizing both the wrist as well as the thumb, because again, remember the tendons that are involved with this condition control the thumb. So if we immobilize both the wrist and the thumb for however many hours you get to sleep at night, that can often be helpful into the day. Similarly, a cortisone injection can often be curative, in that sort of 60 to 75% range, can make it go away forever, which is always the help. The hope. With any cortisone injection, we always mention some risks. I mentioned the idea of in diabetics, it can sometimes temporarily elevate the blood sugar. There's sort of a very rare risk of depigmentation of the skin around the site of the cortisone injection, or something with fat atrophy, where that little fat layer underneath the skin can wear out, so it kind of feels like thin skin. That's where, and for some reason, even though those reactions are very rare, for this particular condition, this is the condition that we sometimes do actually see that. Again, it's nothing that I would say would prevent me from offering somebody an injection. It's just something that we often will counsel folks that is a possibility, although it is a relatively remote possibility. And then again, we talked about the end game for these things, if things don't work, is to do a little surgery. And again, sort of similar concepts. We're just basically opening up the space for these tendons, giving them a little bit more space, and so that they don't rub on that sheath. This is just a little cartoon from the American Society for Surgery of the Hand website, and you can see where those tendons come in. And this is, very cartoony drawing of what it looks like. So those tendons are getting irritated as they rub on that sheath, and that space is too small. So we end up just making a little incision here to open up that sheath. And instead of covering up the tendons, it just sort of opens it up like this, so that they're not rubbing, they don't get inflamed. But we leave that sheath in place so that they don't slide around, they stay in place. And that typically is curative as well. All right, so as we switch gears to move on to the elbow, some of those common themes are going to be a little bit different now, because the most common issue that we see in the elbow is a condition called lateral epicondylitis, which has many different names. You probably have heard of tennis elbow. And then there's even fancier names like enthesopathy of the extensor carpi radialis brevis, which is actually probably the most accurate name, but it's a bit of a mouthful. So tennis elbow is a little bit easier to say. And it's been around for a while. As you can see, it was first described in 1882 from lawn tennis, which I assume is very close to regular tennis. The backhand motion being the big contributor to this condition. And I'll explain why in just a second. So this is a little bit different than the previous two conditions that we discussed, because this is not a true tendonitis or a true tendon inflammation. In tennis elbow, it's actually more of a slightly degenerative process. So that's where you see on my slide here, we have the word tendinosis. It's actually small little micro tears in the tendons that cause trouble. And sometimes the damage processes can outpace our body's repair mechanisms. And then that's where people end up in my office. So a little bit of background on tennis elbow. 1 to 3% of the population will experience this in their lifetime. I'd almost guess that it might even be more than that. I've had it in both my elbows, I could tell you, and I've talked to countless not only patients but family members, friends. Lots of people get this. Is a very common condition. And ladies, you're off the hook on this one. It's equal in male and female populations. And the ages range, but 35 to 50 is sort of the typical age range that we see. Even though I did include a picture of somebody playing tennis and that typical backhand motion that causes trouble, most people that get this don't play tennis. One of the reasons why it's so common is because it, like I mentioned, it does involve the tendons that make your wrist go back like this. And if you notice throughout life, everything you do, you may not notice this because we do it sort of automatically, but when you go to grab something, you do tend to you bring your wrist back, and that just gives us a stronger grip. If you ever tried to pick something up with your wrist bent in this direction, it's very difficult. You get a much stronger grip when you bend your wrist back like this. So all day, all through life, if you pick up anything, you don't think about it first, but you bring your wrist back. And so since we're activating those tendons that bring your wrist back all the time, they're getting a little abused. They're getting a lot of work. Now, you might be saying, well, if it's bringing your wrist back, why are we talking about an elbow? Well, those, again, going back to what we talked about before, the function of a tendon is it connects a muscle to the bone. And so in our forearms, we have muscles on the back of our forearm that connect past the wrist that allow it to go like this when those muscles contract, but they also connect up at the elbow in this spot right here where it typically hurts. And so every time you bring your wrist up like this, even if you put your hands on your elbow, on the outside part of your elbow right now, and you bring your wrist back, you'll feel things moving underneath you. And that's because those tendons are pulling, the muscles are pulling those tendons, and that can start to get a little degenerative if over time with that overuse or just use in general. So this is just a little cartoon again, kind of describing what we were talking about, where this part that's on the outside part of your elbow, and you can get those little micro tears there, and that's where the pain usually is. And again, begins as a micro tear, and our bodies typically have normal healing responses, but if we can't keep up with, if the damage outpaces the healing response, then we end up with the discomfort that comes with the tennis elbow. In terms of treatment, if I don't recommend always going over to Dr. Google and saying anything, so I'm not recommending this, but if you did go to Google and type in tennis elbow treatment, you're probably going to find more websites, pages, recommendations than you would for almost any other condition, because there are tons and tons of treatment options that exist. Typically, and if and little secret, or maybe not a secret, but little insight, if you do that in the orthopedic literature, the same thing's going to happen. So proven orthopedic literature, there's tons of different treatment recommendations, tons of things that have been studied. And typically whenever that's the case, that means that there's no one particular thing that's the be all end all. If you do just this one thing, it's going to make everything better. So the idea is, if there's little micro tears in those tendons, we got to do something to make those little micro tears heal, or get better. So I have my own little protocol for this. And again, there's no one right or wrong thing. I think the protocol that I've sort of developed over years tends to work pretty well when folks do it. But again, I still do some operations for this. So it's not like it works 100% of the time for everyone. So splinting, I'll get to that in a second. There's these counterforce braces, which look to put a little pressure on the forearm to take away the pressure from the elbow where those tendons insert. I'm not a huge fan of those, but I think that there's some role for that. Activity modification. I always tell people, the first thing I tell folks when we talk about the treatment for this is avoid lifting with the palm down, because lifting with the palm down is going to make it worse. Stretching. There's some stretching exercises that stretch out those muscles in the forearm, which are a mainstay of the treatment for this. Splinting. Now I put a splint up here, and you might think, oh, a splint for the elbow? And actually, it's a splint for your wrist. And the idea of the splint for the wrist is, with the wrist immobilized, you're actually calming down the tendons up by the elbow, because again, if you put your hand on your elbow and you go like this with your wrist, you'll feel things moving underneath you. So if we keep the wrist immobilized, we're actually calming down the tendons up by the elbow. And then therapy. So there's different approaches to the therapy, and there's this little bar that you see here. Again, I have no financial relationships with them, but I find that this flex bar works really well. There's a specific set of exercises called eccentric strengthening, and the nice thing about this is you can buy this for $13 on Amazon and be able to do it at home in the comforts of your own home. And I can speak from personal experience as well as from the experience of a lot of my patients, is that it does work. It really does help with this. So in terms of the treatment, in terms of the more invasive types of things, again, if you again, not recommending this, but if you do your Google search, you'll probably come up with at least the 5 things that are on this list as well. One treatment that you may or may not have heard of is something called platelet-rich plasma. This is there are as many studies in the literature that will support the use of this for tennis elbow as there are that will say that it's no better than other things. The science of it does make sense to me, because the idea is that you're removing some blood out of your arm. You're isolating some of the healing factors in that blood by spinning it in the centrifuge. And then you take those healing factors and you re-inject it. Those concentrated healing factors get re-injected into the spot where things aren't healing so well, where you have those degenerative changes, those micro tears, and your body can't keep up with the healing response. The major downside to that is it's not covered by insurance. So there's a kit that needs to be purchased and all that stuff. And hopefully someday insurance will decide to cover it, because I think it would be I think it is a helpful sort of last resort before getting to surgery, or just another treatment that has potential to work pretty well. Again, nothing is 100%. In terms of cortisone, so we used to do cortisone for this all the time, and there are probably still folks that have had cortisone for this all the time. And more recently, there's been some evidence. There were actually 3 really well done studies that looked at tons and tons of data, and they all sort of concluded that folks that got a cortisone injection did exactly what the slide is saying. It treated the acute pain, right? They had excellent short-term relief, but they actually had worse long-term outcomes. So things got worse as time went on. And there's different. This cortisone in tennis elbow could be a half-hour webinar all on its own. I will say in my own practice, I haven't sworn it off completely, because even though those studies were very, very well done, they weren't my exact protocol. So I think that there is a role for it, but my take is that if we can get you better without it, I think that's a better option. So we always try to do some of the other things first, but if we can get you better without it, I think that's a much better option. And then, like all the things we've discussed, there is surgery for this condition. So there's different ways to do the surgery, and I mentioned on the side there that you can either do it open, you can do it arthroscopic. Arthroscopic meaning you make small incisions around the elbow, and you put a camera in to visualize the tendons from the inside out. And there's also a procedure that you use an ultrasound probe. So the goal of all of these surgeries isn't necessarily like in the previous ones, we're removing some kind of constrictor, something that's making the tendons irritated. What we do in tennis elbow surgery is to actually remove the degenerative tissues, remove the unhealing, poor quality tendon that exists, because it's not working very well and it's causing pain. And then that sort of jumpstarts your body's healing mechanisms to come in and make things better. So all 3 versions that I mentioned, there's no proof that any one of them is better than the other. I tend to do it open because I figure in my hands, the post-op protocol is essentially going to be the same. And I would rather get the best look possible. It's still a pretty small incision, and I'd rather get the best look possible and make sure that I'm getting all the bad tissue out with the instruments you see in this picture here, the traditional scalpel. And I find that folks do pretty well when we do it that way. All right, well, I think we have covered the topics in the hand, wrist, and elbow, and happy to open this up for any questions. This is a very good question. And if you need surgery for a trigger finger, what is the recovery for that? And if you don't mind, I'm going to actually talk about the recovery for the all 3 conditions, because I didn't mention that in the talk as well. So with the trigger finger, and again, most surgeons will have different protocols for this. And in my protocol, so again, it's a small incision in the hand, and usually it's about 3 or 4 stitches in the hand to close things up. I like to use stitches that are not absorbable, that do need to be removed, because I find that they're a little bit less reactive. They end up causing less swelling, less irritation. People tend to actually recover a little bit faster, and it's really not that onerous to have them taken out, 3 or 4 stitches. So in my post-op protocol, I give you basically 2 restrictions, which are: I don't like you to get the surgical area wet while the stitches are in, and I don't like you to lift much heavier than like a cup of coffee while the stitches are in. And just to allow the skin to heal and cool down without any wound issues. Once we take the stitches out, which is usually about 10 to 14 days after the surgery, then essentially you're cleared to do whatever you can tolerate. You may not feel like taking on the world at that point, lifting the heaviest thing you've ever lifted, but there's no restrictions at that point. Similar sort of post-op protocol for the Dequervain's tenosynovitis, which is again, for that I make a little bit of a different incision around at the wrist, and I usually weave a little stitch underneath the skin, because it's not in the hand. It's just the healing of the skin in the hand is just a little bit different than other areas. And same deal though. Well, one other change: I usually put you in a little splint that I just like you to leave on for about 5 days, and then after that 5 days, you can take it off, cover it up with a Band-Aid. But again, no heavy lifting, and don't get it wet while the stitches are in. And then for the tennis elbow, the recovery is a little bit different. there are restrictions for about 6 weeks, and I have you wear the wrist brace again afterwards for about 4 weeks afterwards. But again, small incision with the stitch weaved underneath the skin that comes out about 10 to 14 days later. Okay, so next question: where do I do these procedures? We have our group has a surgery center, Mercer County Surgery Center, which is in Lawrenceville, 2A Princess Road, and that's where I have my block time. And these are same day procedure. They all take about between 15 and 25 minutes to do. So you could do them under you could all do them all basically under local anesthesia or with a little sedation. The tennis elbow we tend to give some anesthesia. Just it's a little harder to control the complete comfort getting all the way down to the bone with just a local, but it's possible to do it under straight local as well. I'm sorry, I was just reading this next question. This is a good question as well. Is it better to swing the arm as opposed to using wrist flicking while playing squash or tennis to reduce potential tennis elbow? A flicking motion like that can potentially irritate those tendons that I was mentioning. And so, if the question is to do a more fluid swing, using more of the shoulder than the wrist, then yes, I would agree that would be helpful. All right, moving. The next one is, how long is the recovery period for PRP injection on a golf elbow? So again, different practitioners may have different protocols, but I sort of follow a similar protocol that I would as if you had a surgery on the either the golfer's elbow or the tennis elbow, just to bring other folks up to speed. So I mentioned tennis elbow because that's by far the most common, and tennis elbow occurs on this side of the elbow. Golfer's elbow is essentially the same thing as tennis elbow, but occurs on the inside part of the elbow. Instead of the tendons that bring your wrist back, it's tendons that bring your wrist this way. It's very, very similar pathology as tennis elbow. It's just a little bit less common. Basically, the same treatment protocols exist as well. And in terms of the recovery period, again, I usually will restrict folks in terms of their activities for about 6 weeks afterwards, with incorporating stretching exercises and some in about 4 weeks of bracing afterwards. The goal is, when you do the PRP, you're essentially asking that, for medicine, let's call it, to do the work that a surgery would do. And so in my opinion, if we're asking that medicine to do the work of surgery, then I'm going to treat it like it was a surgery, and we're going to treat the post procedure period sort of like as if we had done the surgery. The next question is slightly off topic, but it is applicable, I think, to these conditions. Someone's asking that they have carpal tunnel and they heard about the MBO procedure WALANT for the operation, in my opinion. So the term WALANT, WALANT, stands for wide awake local anesthesia, no tourniquet. So I think it's fantastic. I think it's wonderful. And in general, I had mentioned, I sort of alluded to the fact in the previous question that the things that I had talked about today basically can be done either just straight local anesthesia or with a little bit of with a little bit of sedation. The WALANT is a very specific, it's sort of specific. Those last two letters, the no tourniquet, is the way that you get around having the no tourniquet is you use a special kind of a local anesthesia that has a medicine called epinephrine, which helps to constrict the blood vessels. And I think it's fantastic. People around the country are doing lots of procedures under that, including wrist fractures, and every day I see a new paper or a new sort of technique video that comes out where somebody's doing a new procedure under that WALANT. I probably, it's interesting. I don't know if the pandemic has had any effect on it, but I feel like since the pandemic started, I feel like there's a huge swing. Most people now, I would say, it's probably 80% of or more of these sort of smaller procedures that I do, people are wanting to do it under just straight local anesthesia. I typically will end up just using the tourniquet for most of these things. So I don't have the full WALANT where I have the the NT is not on there. For these procedures, the tourniquet usually goes on the forearm and it's typically up for 5 minutes or less. And it's really rare that I have anybody complain to me about the tourniquet. Again, it's on for 5 minutes or less, and it's, if you imagine getting your blood pressure taken, and that first time they take your blood pressure where it gets really tight. I understand that could get a little disconcerting, but it gets really tight and then it loosens up. That's sort of what the tourniquet feels like, and most people haven't really had much of a problem with it. The issue with doing it the full wallant is that it works best when you get it in around 30 minutes or so before you start the surgery. So it often involves putting it in the holding area and then waiting, and then before you get to the operating room. So sometimes there can be issues with the timing of it. That's why I haven't fully adopted the full wallant. But again, the main point of the wallant is that it's done under local anesthesia. You don't need any additional IV sedation or anything like that. And like I said, I've been doing most of these procedures that way lately. So the next question is an excellent question as well. With respect to the two tendons controlling the thumb, you mentioned cutting the sheath. How often does the healing of this cut create a scar that is now more constrictive than the original condition? I'll knock on wood while I say this, but I very rarely, if ever, see it in any of the folks that I treat with this condition. I have seen that in sometimes like second opinions or reviewing other folks. So and you read about the potential complications in studies, and it does exist. Sure, it does exist, but it's extremely rare for that to occur. The other thing that in that area, the anatomy of that area is there's a sensory nerve that is basically, when you do the operation, the first thing you do is you find that nerve so you can protect it throughout the operation. Occasionally people will get a little constriction of that nerve, a little irritation of the nerves. Sometimes just retracting that nerve a little bit out of the way causes a little irritation. But it doesn't necessarily mean that there's more scar tissue than there was before. But is it completely unheard of to have people go and have a second release, re-release? Not 100% unheard of, but it's very rare. Is it common to re-tear the TFCC after being repaired already? So the TFCC it stands for triangular fibrocartilage complex, which is a series of ligaments and cartilage that are on this side of the wrist. The last word of that is complex, and it's a very complex structure. There's a number of different things that come together, and it is often a source of trouble on this side of the wrist. There are many different types of tears of that TFCC. So really, the idea of a re-tear would really be dependent on the type of original tear. And even with certain types of tears, you can't even repair them. It's kind of like the meniscus in the knee. Sometimes you just kind of clean up the tear. So it'd be difficult to comment in a broad stroke on how common it is to re-tear. It also any kind of, just in talking about any condition in terms of re-tears, a lot of that depends on activity levels, and in addition to the original tear. Sorry, I can't give you we could talk probably again for 2 hours on TFCC issues, and again, it would be very specific to that particular tear pattern.
It looks like you answered all of the questions. Were you finished answering that question? I apologize. I didn't mean to jump in too soon.
Nope. I think we're good. Yeah.
All right, great. Again, thank you, Dr. Crivello. It was a great presentation. I appreciate your knowledge on all of the upper extremity stuff. We had some really good questions today too. So hopefully it was a very educational program for everyone who participated. And if you are interested in seeing Dr. Crivello, please read the instructions online or on the page. And for an appointment, you can go to our website at www.mbortho.com, or you can call 855-896-0444. Again, thank you so much for joining us today, and we look forward to seeing you next time. Thank you.